Good afternoon, everyone. I'm Brooke Burt, Health Communications Specialist in the Office of the Associate Director of Communications in the Division of Environmental Health Science and Practice at the National Center for Environmental Health at the Centers for Disease Control and Prevention. I'd like to welcome all of you to today's Environmental Health Nexus webinar, Environmental Public Health, Threats in the 21st Century, a primer for clinicians. Today's session will feature presentations followed by Q&A sessions with our panelists. Please note that all participants are in listen-only mode and closed captions are available for this webinar. Next slide, please. Today's EHNexus webinar will be available to view on demand in a few days. You can find the video recording of today's webinar at the CDC EHNexus webpage at cdc.gov/EH-Nexus, or you can scan the QR code. Next slide, please. You may submit questions at any time during today's presentation. To ask a question using Zoom, click the Q&A button at the bottom of your screen. Then type your question in the Q&A box. Keep in mind that we often get more questions than we can answer in a live session, but we will do our best. Next slide, please. Please note that the findings and conclusions in this presentation are those of the authors and don't necessarily represent the official position of CDC. Next slide, please. Before we get started with today's presenters, it's my honor to introduce Adele Johnson, the Deputy Division Director of the Division of Environmental Health Science and Practice at the National Center for Environmental Health, part of the Centers for Disease Control and Prevention. Adele?
Thank you, Brooke. Again, my name is Adele Johnson, and the Deputy Director for the Division of Environmental Health Science Practice. And first, I just want to talk a little bit about what we do here in the division. Our division's overall mission is to prevent exposures to environmental health hazards, to improve health in all communities through applied environmental public health science and practice. And we have 5 branches and 1 activity. The names of our branches are the Asthma and Air Quality Branch. We've got the Emerging Environmental Hazards and Health Effects Branch. We have an Environmental Public Health Tracking Branch, a Lead Poisoning Prevention and Surveillance Branch, as well as the Water, Food, and Environmental Health Services Branch. And in addition to that, as I mentioned previously, we've got 1 program activity, which is Climate and Health Program, which houses all of our climate change scientists here at CDC. We are excited to have medical officers from our branches today to share more about their work and to discuss some important clinically related public health topics with you today. You will learn more about asthma and air quality, resources for dealing with extreme heat, how to take an exposure history, and how to communicate risk. Also, childhood lead poisoning and screening, perfluoroalkyl, as well as polyfluoroalkyl substances exposures, to name a few. And so we have arranged for you to obtain continuing education credits for participating in today's webinar. And, healthcare providers are champions for health advocacy and promotion, and we just want to provide you with the most up-to-date knowledge and useful tools to achieve that goal. We do hope that you leverage what you learned today to improve the health of your patients and communities, and want to thank you for your time. Thank you.
Thank you so much, Adele. Now I want to welcome our presenters for today's EHNexus webinar. We're pleased to have 7 presenters with us today. Dr. Hatis Zahran is the Asthma Surveillance Team Lead for the Asthma and Air Quality Branch in the Division of Environmental Health Science and Practice at the National Center for Environmental Health. Dr. Joy Su is the Senior Medical Officer for the Asthma and Air Quality Branch in the Division of Environmental Health Science and Practice at the National Center for Environmental Health. Paul Schramm is the Climate and Health Program Activity Chief in the Division of Environmental Health Science and Practice at the National Center for Environmental Health. Dr. Michael Ye serves as Medical Officer for the Division of Environmental Health Science and Practice at the National Center for Environmental Health. Dr. Andrea Wenquist is a Medical Officer in the Division of Environmental Health Science and Practice at the National Center for Environmental Health. Captain Arthur Wendell is a physician of environmental medicine and health in the Systems Intervention Section at the Agency for Toxic Substances and Disease Registry. And Dr. Arthur Chang is the Chief Medical Officer in the Division of Environmental Health Science and Practice at the National Center for Environmental Health. Thank you so much to all of our presenters for being here with us today. And now I'll turn it over to Dr. Hatis Zaran. The floor is yours.
Thank you, Brooke. This is Dr. Zahran, asthma surveillance team lead. My team provides asthma statistics on mortality, morbidity, and healthcare use by analyzing data from several data sources. Before I present some of the key findings, I would like to mention how asthma cases are defined to produce these statistics. Next slide, please. To define asthma cases for mortality, emergency department, and hospitalization rates, we usually use ICD-9 or 10 codes, depend on the data year. And these codes are provided in the data sets that we usually analyze. However, for the asthma prevalence estimate, we use asthma case definition that was defined during the 1998 Council for State and Territorial Epidemiology, CSTE meeting. Based on that definition, asthma case definition for prevalence estimate is based on the responses to the 2 survey questions. These questions were routinely included in major health surveys, such as NHIS, Burfis, and Haynes since 2001. Questions are, have you been told by a healthcare provider that you had asthma, and do you still have asthma? Yes responses to the first question, have you been told by a healthcare provider that you have asthma, gives us the lifetime asthma prevalence estimate. And yes responses to both questions gives us the current asthma prevalence. Next slide, please. Based on these case definitions, our findings indicate that asthma affects adults and children of all ages, but affects some population more than others. For example, asthma prevalence is usually higher among boys than girls, women than men, blacks than whites, and people whose family income is below the poverty level than those above the poverty level. Next slide, please. Based on our estimation, about 8% of the population has asthma. 4.5 million of those are children ages 0 to 17 years. About 42% of people with asthma had 1 or more asthma attacks in the past 12 months. Underlying cause of death for 3,511 people was asthma. Asthma as the first listed diagnosis was reported for nearly 990,000 emergency department visits and 95,000 short hospital stays. And data sources as I listed at the slide. I would like to end the presentation on a positive note by saying that asthma mortality rate, current asthma prevalence, particularly among children, and prevalence of having asthma attacks among both children and adults decreased over the years. For more detailed asthma statistics, please visit CDC Asthma Data Statistics and Surveillance website. Thank you for attending. Now Dr. Sue will present.
Thank you, Dr. Zaran, for presenting asthma surveillance data. Can we go to the next slide, please? Okay. Thank you. My presentation will follow hers with some more background about asthma, CDC's National Asthma Control Program, air quality, and pollen, a topic relevant not only to asthma, but also my specialty as an allergist immunologist and internist. As many of you know, asthma is a chronic disease that can be worsened by asthma triggers, including environmental exposures such as air pollution. In the United States, the disease burden of asthma is substantial and unequally distributed, as Dr. Zaran just covered. However, many asthma-related emergency department visits, or ED visits, hospitalizations, and deaths can be prevented by improving asthma control. Next slide. To expand a bit on the last point, asthma control can prevent symptoms like wheezing, coughing, or difficulty breathing, prevent asthma-related ED visits, hospitalizations, and deaths, and decrease missed school and work days because of asthma. Next slide, please. With this background, I'd like to tell you a little more about CDC's National Asthma Control Program, or NACP. NACP was created in 1999 to help the millions of people with asthma in the United States gain control over their disease. The program's goals include reducing the number of asthma-related ED visits, hospitalizations, and deaths, as well as school days or work days missed, and limitations on activity due to asthma. Currently, NACP funds 29 programs, as well as 4 non-governmental organizations. NACP activities and partnerships use the exhale strategies to help people with asthma. In a few minutes, I'll explain more about the term exhale strategies. I also want to highlight that advancing health equity has long been a priority for NACP and continues to be a priority. Next slide, please. Here is a list showing the 4 non-governmental organizations that NACP currently funds. These organizations are the Allergy and Asthma Network, the American Lung Association, the Asthma and Allergy Foundation of America, and the National Environmental Education Foundation. Next slide, please. Now let's go back to the term exhale strategies, which I mentioned earlier. To improve asthma control across the country, NACP developed and is using Exhale, a set of 6 strategies that each contribute to better asthma control. Exhale is the scientific framework that we and our partners use to implement our asthma control activities in public health. Exhale is an acronym that summarizes the 6 evidence-based strategies we prioritize in our asthma control activities. These strategies are not listed in order of importance or impact, but arranged this way to make a digestible acronym. You might wonder why we use this set of 6 strategies. Well, we've learned from prior proven CDC and World Health Organization efforts to address other health conditions that prioritizing a manageable number of strategies, like those shown here, can sharpen and focus what otherwise might be vague commitments to action, and avoid a scattershot approach of a large number of interventions, many of which might only have a small impact. Next slide. In addition to being a set of strategies that each contribute to better asthma control, Exhale can help both children and adults with asthma. Next slide. Also, each strategy in Exhale has been proven to reduce asthma-related hospitalizations, ED visits, missed days of work or school, and healthcare costs. In the following slides, I'll briefly introduce you to each of the strategies in Exhale. Next slide. The first E stands for Education on Asthma Self-Management, which includes providing education on how to use asthma medications correctly, what to do if asthma symptoms worsen, and how to reduce exposures to asthma triggers such as cockroaches or mold in the environment. Next slide. X stands for extinguishing smoking and exposure to secondhand smoke, as tobacco is known to worsen asthma symptoms and lead to asthma attacks. This strategy includes both reducing tobacco smoking among people with asthma, as well as reducing their exposure to secondhand smoke. Next slide. H stands for home visits for trigger reduction and asthma self-management education, which includes intensive tailored education on asthma self-management as described in the first E, and home environmental assessments for common triggers of asthma. Not every person with asthma needs a home visit. Home visit programs tend to be more effective and cost efficient when focused on people at highest risk of asthma attacks. For example, people who have had at least one asthma-related ED visit or hospitalization in the recent past. Next slide. A stands for Achievement of Guidelines-Based Medical Management. This strategy includes strengthening systems that support guidelines-based medical care, including appropriate prescribing and use of asthma controller medications, and improving access and adherence to asthma medications and devices. Next slide. L stands for linkages and coordination of care across settings. This includes linking people with asthma to healthcare and community services when needed, and maintaining communication among those who help people with asthma, including healthcare providers or school personnel. Next slide. The last E stands for environmental policies or best practices to reduce asthma triggers from indoor, outdoor, or occupational sources. This strategy includes facilitating home energy efficiency, including home weatherization assistance programs that support low-income homeowners in repairing their homes, which can thereby reduce exposure to asthma triggers like mold or pests. Facilitating smoke-free policies, facilitating clean diesel school buses, and eliminating or reducing exposure to asthma triggers in the workplace. Next slide. You might have noticed these strategies are complementary. I want to mention that Exhale can have the greatest impact when multiple strategies are used together in every community. That said, every person with asthma in a community does not necessarily need every strategy in Exhale. For example, home visits can be focused on people who have needed recent hospital or ED care for asthma. I also want to reiterate that every strategy in Exhale has reduced asthma-related hospitalizations and ED visits, as well as reduced healthcare costs. Also, the first 5 strategies, that is E, X, H, A, and L, have improved asthma medication adherence, shown by reduced rescue inhaler use, increased asthma controller medication use, or improved asthma medication-related quality measure data. Next slide, please. A frequent question we received is, how can Exhale address social determinants of health and health equity? In fact, multiple strategies in Exhale can improve conditions in the places where people live, work, learn, play, and spend time. Specifically, reducing asthma triggers, for example, through home visits or environmental policies or best practices, can improve conditions in homes, schools, workplaces, and other settings. Also, linkages and coordination of care includes connecting people with asthma to local support services that can improve housing conditions. Next slide, please. Exhale can be used by healthcare providers, public health professionals, people with asthma and their families, school personnel, and others. I encourage you to learn more about Exhale by visiting our website, shown at the bottom of this slide. Here, you'll find resources like fact sheets, a slide presentation, and information about Exhale-related activities in states. Next slide. I also want to highlight that CDC's Exhale website includes guides on using Exhale, including an Exhale guide for healthcare professionals. There's also an Exhale guide for healthcare system executive leaders, for example, hospital leadership or hospital administration staff. In addition, there is an Exhale guide for managed care leaders and staff, as well as an Exhale guide for Medicaid and Children's Health Insurance Program leaders. There's also an Exhale guide for people with asthma, their families, and their caregivers. And all of these Exhale guides and others are publicly available on our website. Next slide, please. For the last part of my presentation, I'd like to spend a few minutes talking about air quality. Other presenters in this webinar series will also discuss factors that can affect outdoor or indoor air quality, such as heat. Shown here is CDC's landing page about air quality. It contains public information and resources that can be helpful for patients and others. For example, on the right side of this slide, we are showing this web page's information about the Air Quality Index, or AQI. The AQI reports air quality for major outdoor air pollutants in the United States that are regulated by the U.S. Environmental Protection Agency, including ground level ozone and particle pollution. Ozone and particle pollution may harm the health of hundreds of thousands of Americans each year, including people with asthma. The AQI value ranges from 1 to 500, with higher numbers corresponding to worse air quality and greater health concerns. On the right side of this slide, the numbers increase going from left to right. When the AQI value is 101 to 150, noted by the orange category, outdoor air is considered unhealthy for sensitive groups, including people with asthma. The general public is less likely to be affected. When the AQI value is 151 to 200, noted by the red category, outdoor air is considered unhealthy, meaning some members of the general public may experience health effects. Members of sensitive groups may experience more serious health effects. When the AQI value is 201 to 300, noted by the purple category, outdoor air is considered very unhealthy, meaning the risk of health effects is increased for everyone. And when the AQI value is above 300, noted by the maroon category, this is a health warning of emergency conditions. Everyone is more likely to be affected by outdoor air when the AQI value is above 300. People can find the AQI in their area on the web, many local TV weather forecasts, and the Air Now app, accessible through the hyperlink shown on this webpage. Or people can sign up for free email tools. You can help patients learn how to access, understand, and use this information, including which action steps they can take based on the specific air quality level. This information can be found through the website shown here. Of note, the AQI does not include pollen counts. That means on some days, the AQI may be low, even though pollen levels in the air are high. I'll get to pollen in a little bit, but first I have one more slide on AQI. Next slide, please. Here are some examples of action steps patients can be advised to take based on the AQI. When the AQI predicts ground level ozone or particle pollution levels will be high, people can choose to spend more time indoors, where levels of ground level ozone and particle pollution are usually lower. They can also choose easier outdoor activities, like walking instead of running, that don't involve breathing as hard. More examples of actions to take are available on the website shown at the bottom of this slide. Next slide, please. I will end my presentation by talking a little about pollen. Pollen is the grains or tiny seeds of some flowering plants, that is, trees, grasses, or weeds. These seeds can be carried on the wind and cause various symptoms, or none at all, in individuals who are exposed to pollen. The amount and type of pollen in the air depends on the season and geographic region. Pollen is primarily found outdoors, but can enter homes through open windows or doors, or passively on hair or clothes. Next slide, please. You are likely familiar with health effects associated with exposure to pollen, so I'll briefly share some examples of how pollens can affect health. Among some people, exposure to pollen can lead to asthma attacks, stuffy nose, that is allergic rhinitis symptoms, or red or itchy eyes, in other words, allergic conjunctivitis symptoms. It's also worth noting that while the primary effect of allergic rhinitis on patients is the effect on their quality of life, the annual direct medical cost of allergic rhinitis in the United States has been estimated to be between $2 to $5 billion. In addition, the missed school and work days associated with allergic rhinitis has been associated with $2 to $4 billion in annual productivity losses in the United States. Next slide, please. CDC has a webpage on pollen and your health, which includes information about how people can protect themselves against pollen during pollen season if they experience pollen-related health effects. These potential steps include checking pollen forecasts on local news and online sources and planning to spend less time outdoors when pollen levels will be high. taking allergy and or asthma medications as prescribed or recommended by healthcare providers, not touching eyes outside, and then washing hands before touching eyes indoors, showering after being outside to remove pollen from skin and hair, changing clothes after being outdoors, keeping windows closed during pollen season if possible, and using high-efficiency filters in the home's heating, ventilation, and air conditioning or HVAC system, and making sure the HVAC system can use the high-efficiency filters that don't violate the system's warranty. Next slide, please. The last resource I'll mention today is related to both pollen, air quality, and asthma. It's an asthma action plan, a personalized plan to help teach people with asthma, their families, and their caregivers to manage asthma. Shown on this slide is CDC's asthma action plan. And on the left side of the screen is the first page of this plan, which includes the green zone and yellow zone parts of the plan shown here. The green zone includes asthma medications to take when a person with asthma has no coughing, wheezing, chest tightness, or shortness of breath, and the person can do their usual activities. The yellow zone contains information about what to do when a person with asthma is in the yellow zone. In other words, when a person with asthma has one or more of the following symptoms: coughing, wheezing, chest tightness, breathing trouble, or waking up at night due to asthma. A person with asthma can also be in the yellow zone if they can only do some, but not all, usual activities. Not shown on this slide is the red zone part of this document. The red zone is when someone with asthma is experiencing an emergency. For example, they're short of breath, or the quick relief medicines have not helped, or their asthma symptoms are the same or worse after 24 hours in the yellow zone. A person with asthma can also be in the red zone if they cannot do any of their usual activities. The asthma action plan also includes steps people can take to avoid exposure to triggers that can make asthma symptoms worse. Asthma triggers can vary from person to person. On the right side of the screen are examples of steps in this asthma action plan for people with asthma symptoms triggered by weather, air quality, or pollen. Thank you for your time, and I hope you found my remarks helpful to your valuable work. And I'll turn it over to the moderators.
Thank you so much, Dr. Saran and Dr. Sue. And we have time for a few questions for this section's presenters. To ask a question, just as a reminder, you can click the Q&A button at the bottom of your screen and then type your question in the Q&A box. But it doesn't look at this time like we have any questions, but maybe someone might be working on typing that in. Did any of our other presenters have questions?
Hi, Brooke. While we're waiting, I'd like to ask a question. So can you tell us about what other environmental triggers may be at home for asthma patients that clinicians can ask about?
I am so glad you asked that question. I'm not sure, but I think if I have it, I'll mention indoor tobacco smoke, mold that can grow indoors, cockroaches, dust mites, furry pets for some people, dog hair, cat allergen. Those are some common ones. And there is CDC actually worked with EPA and the US Department of Housing and Urban Development to develop a checklist for home visitors that can be used to go in and assess for these common indoor asthma triggers. And the checklist also provides low-cost action steps that can help people reduce exposure to these asthma triggers in the home. And this checklist is also available not only in English, but also in Spanish. And there is there's a slide set, almost like a training slide set that can be used for additional background information. And after this, we can share that those links in the chat.
Thank you.
Sure.
Thank you. We did have a couple of other questions come in. The first was, what is the emergency intervention for an asthma attack?
Well, I think that is a great question. That typically, clinically, as many of the audience knows, the first step is to use whatever rescue inhaler is prescribed. You know, with current guidelines, it could, and depending on the individual with shared decision making, it could be something like albuterol or levoalbuterol. But with the current guidelines, depending on the patient and provider's decision, it could be a combination short-acting beta agonist and inhaled corticosteroid. So that is, as the asthma action plan says, that's the first step. And as many of you in the audience counsel, that is the first step. But if symptoms don't get better or they get worse, and the sort of the next intervention is to really think hard about either calling the healthcare provider's office or going to the emergency department or calling 911, depending on the severity and the acuity of symptoms.
Thank you. And then we had another question come in. Is mask wearing an effective measure to mitigate pollen exposure when outdoors during high pollen conditions?
Thank you for that question. At this time, that is, I think that's a very complicated question for which the evidence is not yet, we don't have the evidence as an agency to recommend mask wearing, but we would direct you to the interventions that that I described, sort of trying to stay indoors, trying to close windows, trying to wash off any pollen or change clothes to reduce that exposure. But that's definitely certainly an area of interest that we hope to continue to work with our partners to look further into in the future.
Thank you. And we had another question come in that said, what are some options for people who don't have access to meds because they live in a rural community?
I think that's a really important question as well. There is a role, I don't know all the details about this rural community, certainly, but there are some, I would say one resource is to potentially reach out to your state health department or local health department to see if there are local resources or rural resources. I know we support many state health department asthma programs across the country, some of them with a high number of rural populations are actually intentionally trying to improve access to care in rural communities, working with local partners, EMS, et cetera. So that's one resource to certainly follow. And we can, so I would call your health department, your state health department. There's also a potential role to, time's limited in the clinician's office, but if there's time, there's a potential role for kind of developing when the patient's in the office or telemedicine visit preventively. There's a role for kind of thinking ahead about what to do in the event of emergency and you're far away from medical care, like in addition to, what emergency medicines could be prescribed so that patients could have that on hand in the event that that's their first step before they can, so to kind of help their symptoms on their way to getting emergency care or waiting for emergency care to come.
Thank you so much, Dr. Sue. We will now hear from presenters discussing heat and HELP, starting with Paul Schramm. Paul?
Right. Thank you, Brooke. And hi, everyone. I'm Paul Schramm, and I am the chief of the Climate and Health Program here at CDC. So we'll go on to the next topic of the day, heat and health. Heat has a very significant impact on human health. Our data shows that from 2004 to 2018, an average of over 700 heat-related deaths were reported each year. And we see this number has been increasing as more recent data from 2019 to 2021 shows the number has increased to over 1,200 deaths per year. And we know this is still likely an underestimate. It's based only on death certificates that specifically list heat as the cause of death. So we think the actual number might be quite a bit higher than this. In addition, we also see an average of over 67,000 emergency room visits due to heat each year in the United States. Heat's also a worsening problem in a changing climate, with heat events becoming more frequent, more intense. The average annual temperature has already increased by 1.2 degrees Fahrenheit over the last 30 years, and is projected to increase another 2.5 degrees by mid-century, with a wide range of resulting health impacts. Next slide. One example of a recent heat event with major health impacts occurred in June 2021 in the Pacific Northwest, as well as parts of British Columbia, Canada. All-time temperature records were broken in multiple cities in the US. In fact, I think in Portland, Oregon, they had temperatures one day that were 40 degrees above normal. So it was extremely hot and very historic and dangerous heat wave. In a CDC report published about the event, my colleagues and I used syndromic surveillance data to track heat-related emergency room visits in the region. The mean daily number of heat-related illness emergency department visits for June 25th through 30th, 2021 was nearly 70 times higher than during the same days in 2019. So we saw a huge public health impact from this in the week when this heat wave was occurring. We expect more heat waves like this as they become more frequent with climate change. Next slide. So there are a number of things that determine someone's heat risk, a lot of different factors. It's a combination of both individual factors and environmental factors. This graphic outlines some of those. So you can see on the left some of the individual factors, things like being dehydrated, having underlying health conditions, an outdoor worker, outdoor athlete. These things all can add to your risk from an individual perspective, and we'll hear more about some of these in the upcoming slides from my colleague. And then on the right, you can see an environmental exposure standpoint. So of course, higher temperatures, worse humidity, a lot of direct sun exposure. These are all things from the environmental side. So it's really this combination of things that determine an individual's risk from heat and kind of what health impacts they're going to experience. On to the next slide. I'll turn it over to my colleague, Dr. Art Chang, the Chief Medical Officer in our division, to talk more about symptoms, impacts, and clinical guidance around heat. Art?
Great, thank you, Paul. And good afternoon, everyone. Next slide, please. Okay, so one of the most important ways that we can reduce the health impacts of extreme heat exposure is to spread awareness of signs and symptoms of heat-related illness. So as everyone knows, heat illness is a spectrum with varying degrees of severity, starting with heat cramps after someone begins to overheat. So at this point, the core body temperature may be normal, and the symptoms may include thirst, muscular pain, and spasms. And this is often the first signal that the affected person is struggling with heat exposure, and this is the best time for intervention. Next, as the core body temperature rises, we begin to reach heat exhaustion, and the affected person may show signs of generalized weakness, sweating, anxiety, dizziness, and even feeling faint. So this is a form of severe heat illness and often requires urgent medical treatment, such as IV hydration and rest in a cool environment. And in extreme cases, when the body, with the core body temperature exceeds 103 degrees, we reach heat stroke. The hallmark for this part of the spectrum is altered mental status. And this is a life-threatening situation which requires emergent medical attention. So with heat stroke, the affected person may have confusion, may have disorientation. They may have syncope or near syncope and have excessive sweating, or worse yet, have decreased sweating because of hypovolemia. Next slide, please. So some advice that you can give your patients in order to protect themselves from heat includes staying cool, staying hydrated, and staying informed. Staying cool with behaviors like wearing appropriate clothing, staying indoors during hot hours, and by never leaving children or pets in hot cars. Staying hydrated, especially during strenuous activity outdoors, but even at rest because of insensible losses in hot environments. It's also important to actively stay informed by checking your local news, knowing the signs and symptoms of heat-related illness and what to do, and monitoring those at high risk of heat-related illness in events, particularly those with high sensitivity and low adaptive capacity. Next slide, please. Heat also disproportionately impacts some people more as compared to others. So scientific literature describes communities of color, older adults, children, and low-income communities as populations at higher risk. Broadly, there are 3 factors that affect risk from extreme heat events. So these are the environment or heat exposure, or how hot it is, someone's sensitivity, such as extremes of age, young or old, and their adaptive capacity, whether someone can thermoregulate by sweating more or having the means to alter the environment, such as buying an air conditioner or fan. Next slide, please. So when looking to protect your patients from hot weather, assess your patient's risk factors for heat impacts on their health. You can use this questionnaire that CDC developed called Chilled Out, and we will cover that in the next slide. You should teach your patients how to know when heat is dangerous to their health. So show your patients how they can use the heat risk tool, an online forecasting website for local forecasting. And another environmental variable to consider is the air quality index, and explain how poor air quality can make heat risk worse. And then finally, help them develop a heat action plan. Review behaviors to stay cool, stay hydrated, and know how to recognize heat-related symptoms and when to seek medical assistance. Help your patients understand what to do when air quality is poor, especially if they have cardiovascular or respiratory disease like asthma that my colleagues had presented on in the previous presentation. And then also develop a medication plan for those hot days. Next slide, please. Okay, so you can use this questionnaire to assess risk factors from heat or poor air quality. This tool is called Chilled Out, which is spelled out with CHILLDOUT. So the letters stand for C for cooling, and you should ask your patients questions like, does your patient have working air conditioning or fan? Can they check and control indoor temperatures where they live? Do they know how to locate a cooling center nearby if needed? H for housing. Does your patient have stable housing? Do they live on a higher floor where they may be exposed to more heat? Are they regularly exposed to indoor air pollutants such as secondhand smoke or mold? Do they have a portable air purifier or a filter in their HVAC system? And then I for isolation and mobility. Does your patient have a neighbor, friend, or family member who can check on them during heat waves? Does their mobility limit their ability to seek cooling in their home or elsewhere? And then E for electricity. If excessive energy demands during extreme heat leads to a power outage, which is very frequent, does your patient have a plan for refrigerating their medications like insulin, and or having a backup plan for electric medical devices like CPAP machines? L for learning. Does your patient check weather forecasts to know the hottest time of the day? Can they access the online heat risk tool or other information about how to protect their health from heat? What change in protective behaviors do they take to do so. And then D, does your patient take medications that increase risk from heat exposure? And we'll be covering these in the next few slides as well. And then the last four or three letters, OUT for outside. How much time does your patient spend outdoors for work or recreation? Are they exposed to outdoor air pollution at home, work, or elsewhere, such as from a major roadway, construction site, industrial facility, or frequent wildfire smoke? Do they have allergies to grass, weeds, and tree pollen? Next slide, please. So now I want to highlight the heat risk tool and how your patients can use this, which is a free online tool that's health-based. So what the heat risk tool does, it integrates health and temperature data to deliver a 7-day outlook for hot weather. Heat risk uses a 5-level scale to indicate how much risk the heat level is in a specific area, which includes a specific zip code. Each level uses a color to represent risk from heat exposure. This tool also accounts for unique relationships between heat and health at the local level in different locations and different times of the year. Heat risk also accounts for the role of humid air, which can amplify heat-related health risk. So this tool was developed by the National Oceanic and Atmospheric Administration, or NOAA, National Weather Service, and our health scientists here at the CDC. Next slide, please. So then all this information can then be used to make a heat action plan with your patient. To summarize this, first, please advise them on ways to stay cool, such as staying in the shade, using a fan or air conditioning, and checking the CDC heat risk dashboard to predict hot days. Second, discuss the importance of staying hydrated and knowing the symptoms of heat-related illness. Third, be aware of symptoms that may include severe sweating, shortness for breath, dizziness, headache, tiredness, weakness, and nausea. Fourth, patients can also check the air quality in their area because extreme heat and poor air quality are correlated and may have synergistic effects in certain patients, such as people with asthma. Fifth, have a plan for having medications available and properly refrigerated in cases of power outage. Next slide, please. So we had mentioned that medications may be a risk factor for heat illness. And this is because certain classes of medications can interfere with regulation of normal body temperature or water balance. Some examples of these include antipsychotic medications and certain antidepressants, which may have anticholinergic effects, which decrease sweating. Also, patients with cardiovascular disease may be on diuretics and antihypertensives, which causes shifts in homeostasis and fluid, as well as ways that your body can adapt to fluid loss. So heat can negatively impact some medications, and patients need to be counseled on how to best store their medications when temperatures are high. So for example, some of these are inhalers, EpiPens or auto-injectors, and then and also insulin. I'm a practicing emergency medicine physician, and I can tell you, I've seen many patients that come in with hyperglycemia, despite them using their insulin. However, this insulin likely is not efficacious because of being stored improperly. And then also some medications can increase skin photosensitivity, and counseling or using sunblock can help protect your patients. And some examples of these are antifungals and some antibiotics as well. Next slide, please. So clinicians should review their patients' medications and consider making temporary adjustments to medication doses or frequency based on the risk of interaction with heat. And this is especially important for older patients who take multiple medications that may amplify risk of harm from heat via different mechanisms. For patients with fluid restrictions, such as those with congestive heart failure or renal disease, please consider increased insensible losses from extreme heat, especially if they're already on other cardiovascular medications as well. Have your patients identify a point of contact to check on them, especially for older patients and patients that may have mobility issues or live in places that may not have a lot of neighbors or contact with other persons. Counsel your patients to watch out for heat illness and which symptoms require seeking immediate medical assistance. Next slide, please. So you can find additional resources that CDC has created for you that you can share with your patients. And these are all on our website. So they include a lot of public safety messages, such as hot weather tips, public health guidance documents, multimedia videos, resources for children, infographics, social media, and also heat and health data. So I will end my piece here, and I will turn over to Paul for the next few slides. Thank you.
All right. Thank you, Art. I'm going to talk, well, first I want to emphasize those resources that were on the last slide. We have a lot of things on our website, and these can be really useful in your work. So if you haven't seen these or you're unaware of CD's heat resources, I strongly encourage you to take a look at this. On to the next slide. I'm also going to talk a little bit about some other federal resources because we don't work in a silo on heat. We work with a lot of different federal agencies. In fact, there is a cross-federal group that CDC co-chairs, and we launched heat.gov about 2 years ago. So there's a lot of different resources from us and our partners as well on heat.gov. Hopefully some of you are familiar with this. It's kind of the landing page for heat in the federal government. It links back to a lot of our resources as well as resources from other federal and nonprofit partners. On the next slide, I also want to talk about some CDC resources elsewhere. So our climate health program has those resources that I just mentioned. We're located within the National Center for Environmental Health, but there's also a lot of great heat resources from the National Institute for Occupational Safety and Health, or NIOSH, which is part of CDC. They have quite a few here. You can see some different screenshots of some of the things that they have. These are for safety and health professionals, for employers, for workers. So there's a number of different audiences that are served here. One that I really want to highlight because it's one of their most used and most popular products is they worked with OSHA, the Occupational Safety and Health Administration, to create the OSHA NIOSH Heat app. So this is a freely available, downloadable app, and what workers or employers can do is they can put in their exact location, and it calculates the heat index based on that specific location, and then offers tailored precautions based on the risk level there. So that's, I think, really useful in the workplace. And again, you can access all of these tools that NIOSH has and resources on their heat website. On to the next slide. Getting into a little bit more into the federal collaborations on this, and just to highlight that it's not just CDC working on this. For many years, really, federal agencies did work separately on components of extreme heat. There was a lot of siloing. So to better serve the American people on this issue and provide kind of a coordinated federal response, NOAA, the National Oceanic and Atmospheric Administration, and CDC launched NIHIS, or the National Integrated Heat Health Information System, back in 2015. And that's the group that eventually launched heat.gov. And this NIHIS was really established to develop and provide actionable science-based information to help protect the nation from heat. So NIHIS is an integrated approach to providing expertise and decision support services, really designed to build resilience and, in the end, reduce heat-related illness and death. So NIHIS spans many U.S. federal agency missions and mandates to deliver these solutions faster, more efficiently. And you can see a list of all of those federal partners on the right side of this slide. So there's quite a few of them, including our sister programs within the Department of Health and Human Services. NIHIS also has an interagency work group where we do all of this planning, as well as an external partner network. So it allows us to engage with state, local, tribal, territorial, non-governmental, and academic partners on heat to develop a national heat strategic plan that we released earlier this year, and also a few international partnerships on heat. Next slide. I also wanted to give a few examples of what health departments are doing around the country on this and how that kind of relates to the connection between broad level public health work and clinical action on heat. So these next three examples are from CDC's Climate and Health Program, which provides funding and technical assistance to 13 different jurisdictions around the country to prepare for and respond to the human health impacts of climate change. So that's a lot of things. That's hurricanes, wildfires, vector-borne disease, but it also includes heat, and all 13 of those jurisdictions are working on heat. One example here is from Health Department in Arizona, and the three examples I'll show have just really innovative projects to address extreme heat. So what Arizona is doing is focusing on cooling centers. So they completed an evaluation of best practices on cooling centers, as well as the locations of their cooling centers and gaps in order to improve access and protect residents from extreme heat. They have a system where heat alerts are sent out to over 29,000 subscribers on these extreme heat warning days. And the heat alerts include heat safety information, a lot of the things that Dr. Chang shared, and also information on where local cooling centers are. So maps, clickable links where they can find their local cooling centers to help people stay cool during these heat events. Also, in an effort to expand the use of cooling centers, Arizona used local data to determine new cooling center locations, really the neighborhoods where they were most needed, in order to meet demand and help support the most at-risk populations with a focus on Maricopa and Pima counties. So that's just one example of how a health department is doing this in the state of Arizona. Next slide. The city of San Francisco is also taking on extreme heat. At the city level, demographic factors and the urban heat island cause disproportionate impacts across neighborhoods. And in San Francisco, they're seeing this even on a block by block basis, with risk and temperatures being different on every block. So what the city did was to create a heat vulnerability index. They used 21 different local variables that they had, locally collected information on health, land cover data, tree data, things like that, to identify the most at-risk areas in the city. So this index now informs city planning decisions, education efforts, and designated cooling centers. And on to the next slide. Sorry, one more. Thank you. So the Rhode Island Climate Change Health Program is the last example I want to share. They've done a lot of work on New England. A lot of people don't necessarily think of New England when they think of heat, but it's actually a big problem there because there's a low prevalence of air conditioning and people aren't accustomed to the heat. So the Rhode Island Climate Change and Human Health Program works on a lot of different things like community resilience, extreme heat, air quality, respiratory illness. But with heat, what they saw were that certain populations, including older adults, youth, outdoor workers, and residents in urban heat islands were being most impacted. So that's something we see similarly across the country, but Rhode Island was seeing that in their local data as well. So they partnered with surrounding states in New England to create a regional heat collaborative. And this collaborative used data to show that the health impacts were occurring well below the thresholds for heat alerts. So for example, the National Weather Service might have been releasing a heat alert or heat warning at certain temperatures in Rhode Island, but they were seeing health impacts were happening below those temperatures. So through this regional collaborative, they worked with their local weather forecasting office and the National Weather Service to change those thresholds. So now those heat alerts are called earlier at lower temperatures and are directly informed by that local health data. So this is something that they're hoping will help to save lives as they see these emergency department visits and health impacts, even when the temperature is not as high as you might expect. So on to the next slide. Those were just 3 examples. There's a lot more. I encourage you to check out CDC's Climate and Health Program website, where we have success stories, including on heat, from all of the jurisdictions that we funded. And with that, thank you, and we will go on to Q&A. Brooke.
Thanks, Paul. There was a request to go back a couple of slides, Renee, to see the San Francisco slide. The one right before this one. Yeah, right there. Just kind of wanted to stay here for just a second so that y'all can review that information that Paul presented. Some great images there.
Yeah, sorry. I think we were on the Arizona slide for a little bit extra while this
It's
one
all
was up.
good. I just didn't want anybody to miss the pictures.
Yeah,
It's
so
good stuff.
just to emphasize here that they use those 21 local variables really to look at very downscaled geographies to look at what the risk level was.
Wonderful. Thank you. All right, Renee, we can advance on to the Q&A portion. So we do have time for a couple of questions that have come in. The first question is for Dr. Chang. In the chilled out method for housing, why ask if they are regularly exposed to tobacco, smoke, or mold? What is the relationship to heat-related illnesses?
Great. Thank you for that question. So we know for a fact that people that have respiratory disease like asthma are impacted more by heat as well. We also know that during heat waves, people are going to be indoors more. So the reason why we want to ask to make sure they have good indoor air quality is because they're going to be exposed to those allergens or other triggers more because they're indoors more. So at this point, then it will be very important to make sure that if you have someone who smokes in the house, that hopefully they can cut back on that behavior, at least until the heat wave is over and people can get more fresh air. And then also, it will be very good to check your filters to make sure that the increased time that you're spending indoors from the heat wave, that you have clean indoor air so that you may not cause more triggers for asthma or other respiratory diseases. Just going to outdoor air, we know that during heat waves with hot weather, there's also increased ozone, for example, and ozone is a respiratory irritant, which also adds to that adverse effects on people with respiratory illness.
Okay, thank you so much. Another question that came in, I'm originally an East Coaster and the humidity plays a huge factor in heat and heat perception. How much does humidity play a factor in this planning?
Yeah, great question. I can answer that one. So a big factor, we know that humidity affects people's ability to cool down by sweating. So that is a factor in everything that we do in all of our tools. And when we look back at past health impacts, that's kind of built in. So for example, when we do kind of exposure response relationships, when there's higher humidity, we see more of a response. That is more people going to the emergency department. So then when we use that health data to inform our heat risk and our work with the National Weather Service, humidity is kind of built into that. We also encourage clinicians, local health departments to be aware of this and to know that the humidity is a big factor in people's risk to heat-related illness.
And I just want to add a little bit to that, you know, the heat risk tool does take into account the humidity levels as well. And all you have to do is really just type in your zip code. So I don't know, Paul, can you just share a little bit more about the heat risk tool?
Sure. So that the heat risk tool is something that we hope everyone will use. We developed it with the National Weather Service, and it's a 7-day forecast that is based on local health data. So previously, when the National Weather Service would release a heat warning or a watch, sometimes it was based on health data, sometimes it wasn't. Most of the time it wasn't. It's local weather forecasting offices who did that. So you might be aware of your local weather forecasting office. For example, where CDC is located, it's the Peachtree City Weather Forecasting Office. And those offices actually are the ones who release weather-related alerts, including heat warnings and watches. So by working with the National Weather Service to include health data nationally, that means you can go in, you can enter your exact location, and you'll get a color-coded heat warning for each of the next 7 days. So if you're trying to see what you might be seeing in your patients, or if a health department is trying to plan to put out communications or opening a cooling center, you can click 3 days ahead, 4 days ahead, 5 days ahead, and get a color-coded warning level. So if you see, oh, it's orange or it's red, that might change how you're preparing in your specific area for the upcoming heat.
That's great. Thank you,
Hey.
Paul. Another question that came in, what resources do you have for rural communities? What can I expect from the CDC in terms of access and equity to resources and inclusion in health preparedness programs?
Yeah, I can start with that and see if Dr. Chang has anything to add. First are the heat risk tool and the other tools that we have, including one called the Heat and Health Tracker. You can enter in your specific zip code. So for rural areas, it will give you local information. And we do see that on a per capita level, many times heat-related illness is worse in rural areas, potentially due to lack of access to healthcare or longer distances from emergency care. So people talk a lot about the urban heat island. In cities, that is definitely a big problem. But on a per capita level, sometimes in rural communities, we see that it can be more of a threat. So we do have resources, as I mentioned, all of our tools cover rural areas throughout the United States. We also have some specific resources for tribal areas, for agricultural workers. And then I mentioned the tool through NIOSH, the National Institute for Occupational Safety and Health. They have resources for workers that are more likely to be in rural areas, such as agricultural workers. So there's definitely a lot of resources on this. We have a lot of downloadable data on this as well.
Great, thank you. So I do want to thank you, Dr. Lucy Jones, for asking that question. Yeah, certainly, I think a lot of the tools and information that we put out, you know, you will need to have access to high-speed internet or cell phones, and things like these may not be available to a lot of the rural communities, or may be harder to get. So I think that they will be dependent then on you, Dr. Jones, on your knowledge and you know, the way that you can talk to your patients and give them, you know, credible information. So I applaud that you're asking all these questions. The other thing I want to call into attention is that CDC does have a rural health initiative, and I will put that in the chat. As you already mentioned, I think this goes way past not only heat, environmental health, and access to healthcare, or you know, transport and you know, transferring patients from rural areas to other urban hospitals. So, but anyway, I think that maybe you can start at the CDC rural health website, and then, you know, please reach out to me if you have any additional questions. Thank you.
One other thing I'll add to that is one issue in rural areas is that there often aren't really cooling centers. There might not be an opportunity to have those. So something that we do have within our Department of Health and Human Services is LIHEAP, the Low Income Home Energy Assistance Program. That's located within the Administration for Children and Families. It was originally set up to provide heating assistance during the winter, but now it's used for cooling assistance. So everywhere, including in rural areas, people can apply and receive funding so that they're able to run their air conditioning and to be able to be safe in their own home and receive utility assistance to be able to do so. So that's been something that we've seen a lot in rural areas where people might not have access to a public place or a cooling center to go when the temperatures are high.
Thanks to you both. Another question came in. Is there any guidance that you can offer for students who are engaged in activities outside? Is there a resource that student health centers might be able to use to keep active students or students in general safer?
Yeah, we do have a training at CDC for mainly high school athletes and for the staff that works with them, such as coaches, teachers, and school nurses. So it's not necessarily all students, but I think a lot of the things for student athletes are relevant to all students, and kind of how things, that training goes through different interventions and actions that can be taken to protect health of high school age students during heat waves.
Thank you. We had a couple more questions. Would it be a good idea for a physician's office to train on using the heat risk tools so they're able to demonstrate it to patients?
Yes, absolutely. I think that you'll get a lot of information, and then doing a little demo, I think, for your patients will be very helpful. There also think about other ways that you can be able to deploy this. For example, if you have people in your waiting rooms that may have access to this, you could have them use their cell phone to at least play with this website, and then you can follow that up with more questions once they see you in your office.
Thank you, Art. And then one more question is that, are there any safe technological advancements to address heat and climate change? It seems that having an AC is no longer a luxury, but a necessity. However, those come with their own impacts. Could you address that?
Yeah, so this is a great question about kind of the interaction between adaptation and mitigation. So adaptation is everything we've been talking about. Heat is already happening. What actions do we take to protect people? But we also want to be wary of our greenhouse gas emissions and the things that are driving climate change. And that's definitely a tension when we're talking about using more energy to run ACs more. So one way to deal with that is by using renewable energy to power the AC. So of course, that's not something that necessarily an individual clinician can control, but that is one way to deal with it, so that the impact that additional electricity use is having is not creating worse problems or worse air pollution. So solar, geothermal, wind energy is a good way to reduce those health impacts.
Wonderful. Thank you. Thanks to you both. That wraps up our questions for this section. Welcome back, everyone. I did want to note that we have dropped a couple of pieces of information into the chat for you. Several of the links that were requested for the last section, as well as the ehnexus@cdc.gov email address, where you can send any follow-up questions for any of the presenters. And now we'll move on to our next section, where we will hear from Dr. Michael Yeh. Dr. Yeh, the floor is yours.
Thank you very much, Brooke. I'm Michael Yeh. I'm a medical toxicology physician here at CDC's National Center for Environmental Health. And today I'll talk about taking an exposure history and also touch on the importance of good risk communication. Next slide, please. So as we all know, human health is very closely interconnected with the environment, and it is estimated that environmental and occupational factors contribute to approximately 25% of global disease, either directly or indirectly. Healthcare providers play key roles in detecting, treating, and preventing disease from toxic exposures. However, we as clinicians often do not address occupational and environmental history adequately with our patients. Also, hazardous exposures are often not considered in formulating differentials, leading to missed opportunities to make the correct diagnoses. So I'd like to highlight some areas where we could potentially do better in our practice to help our patients. Next slide. It is very important for all clinicians to consider taking an exposure history as part of their routine practice. Many environmental and occupational diseases can present initially as common medical complaints or nonspecific symptoms if the exposure is not identified. As a result, patients might receive inappropriate treatment while continuing to be exposed. Coming up with a correct diagnosis can stop further exposure and prevent disease in other people who might be potentially exposed as well. Toxic exposures can affect many different organ systems, and health effects can be acute or chronic with varying latency periods between the exposure and the onset of disease. Next slide. So this slide outlines some of the goals of taking an exposure history. First, of course, we want to identify the hazard. And when you know what the hazard is, you can counsel patients to avoid or stop the exposure. This allows one to prevent disease if possible. If a disease cannot be prevented, the information that's gathered can help identify and treat the disease early. And in some cases, clinicians may be able to arrest or reverse disease progression. Next slide, please. After an acute toxic exposure, symptoms can often occur very soon after the exposure. Many substances also display a dose-response relationship with higher levels of exposure, resulting in more severe adverse health effects. But compared to infectious diseases, patients with acute toxicological exposures might be less likely to present with a fever as a prominent initial symptom. However, it is also important to keep in mind that there are some toxins that can cause hyperthermia. So therefore, an elevated body temperature does not necessarily rule out a toxic exposure. In some cases, animals and livestock might become sick or die before or around the same time that human cases are identified. And also, many people who are exposed to a toxic agent at a dose high enough to produce a response may experience similar physical reactions and symptoms. Next slide. Sometimes toxic agents can cause a unique set of signs and symptoms called toxidromes. Clinicians who recognize these toxidromes may be able to identify the general class of toxin that is responsible for causing their patients' illnesses. However, many toxic agents do not have a specific toxidrome. And in fact, as I mentioned before, many patients present initially with nonspecific signs and symptoms. So things like nausea, vomiting, or dizziness that could be symptoms of many different disease processes. These are common findings associated with both toxic agents as well as infectious diseases. Also, even toxic agents that are known to be associated with a toxidrome might not cause all of the symptoms all of the time. We can therefore think of toxidromes as being specific, but not necessarily sensitive. So the absence of a clear toxidrome does not reliably exclude exposure. It can be especially challenging to diagnose patients who are exposed to mixtures of more than one substance as well. Next slide. So here are a few examples of classic toxidromes. And please keep in mind, this is not an exhaustive list. I know this is a busy slide, and I also don't expect you to absorb and digest all of this immediately, but this might be something that would be worth reviewing after today's webinar. So one example is the cholinergic toxidrome. Signs and symptoms of the cholinergic toxidrome include salivation, diarrhea, lacrimation, excessive respiratory secretions or bronchorrhea, as well as excessive sweating or diaphoresis and urination. So just think of a patient looking really wet with profuse secretions. And patients can also have constricted pupils, as well as muscle fasciculations, weakness. They can present with either a slow or fast heart rate, so bradycardia or tachycardia, either a low or high blood pressure, hypotension or hypertension, as well as altered mental status or seizures. So some examples of toxic agents that can cause the cholinergic toxidrome include many common insecticides, such as organophosphate insecticides, nicotine, and medicinal carbamates as well. So one example of a drug that falls in that class is physostigmine. Patients with the anticholinergic toxidrome typically have flushed skin, dry skin, and their mucous membranes can be dry as well. Typically, they can have a high body temperature, and when you look at their eyes, you may see big, dilated pupils. Their heart rates can be abnormally fast, so tachycardia is a prominent finding. Blood pressure can be high as well. Patients might also have hallucinations, seizures, and urinary retention. Anticholinergic agents can include common medications such as antihistamines like diphenhydramine if taken in overdose. There are also plants such as belladonna, nightshades, or jimsonweed, as well as others. There are many agents that can act as hallucinogens. They can cause not only hallucinations, but disorientation and anxiety and panic as well. So these can include substances such as LSD, PCP, peyote cactus, psilocybin-containing mushrooms, and others. Sympatomimetic substances tend to cause high blood pressure and a fast heart rate, as well as an elevated body temperature, anxiety, and agitation. So compared to the anticholinergic toxidrome, patients will often be sweating profusely rather than having dry skin. That is one clue that can help you distinguish between the anticholinergic versus sympatomimetic toxidrome, where sympatomimetic patients tend to be sweating rather than having dry skin. On physical exam, their pupils might also be dilated, and deep tendon reflexes can be increased with hyperreflexia. Sometimes patients might also have seizures, and examples of some sympatomimetic agents include substances like amphetamines, cocaine, khat, and cathinones, such as the so-called bath salt and ephedrine. Opioids, as we all know, are substances of significant public health concern these days. And people suffering from the effects of opioids can have respiratory depression, lethargy, and constricted pupils. This can also progress to hypotension, bradycardia, pulmonary edema, and coma. So examples of opioids include common prescription medications such as hydrocodone, oxycodone, codeine, and others, as well as non-prescribed substances such as heroin and fentanyl. Next slide, please. So in contrast to acute poisonings, I'll talk a little bit here about chronic exposure. So chronic exposures and the long-term health effects from these exposures may be much more challenging to identify and diagnose. As noted before, patients may initially come into the office presenting with nonspecific symptoms. So sometimes the exposures of interest might have occurred a long time ago in the past before the patient even presents to the clinician. Sometimes chronic exposures may occur over long periods of time, especially with occupational settings or environmental exposures. The time period can be months or even years. The severity of adverse effects also associated with chronic exposures may be influenced by the dose as well as individual factors. The dose can depend on the amount and concentration of the substance in question, as well as the frequency of exposure, duration of exposure, the route of exposure, and the extent of absorption into the body. Individual factors can also include a patient's age, their gender, any underlying chronic medical conditions, and genetic factors. And these can all influence a person's risk of developing adverse long-term health effects. Next slide. Patients who are concerned about a possible environmental or occupational exposure will need a comprehensive and thorough evaluation. Very often, this will require a dedicated visit to address their concerns. And this might be especially challenging in a typical primary care practice when the amount of time we get to spend in patient encounters can be very limited. So therefore, it is often useful to ask patients to complete a self-administered questionnaire regarding potential exposures prior to the appointment. So these images here show an example of some of the contents of a typical exposure history form. Ideally, the clinician should be able to review the completed questionnaire before seeing the patient. So you can use that time that you have with the patient to explore any potential exposures in more detail. So an example of this self-administered questionnaire is available through CDC and ATSDR on our website, and the link will be provided at the end of this presentation. And clinicians can use the patient's responses to the questionnaire to craft more detailed interview questions during the patient encounter. Next slide, please. So now I'll talk about the sources and pathways for toxic exposures to occur. So here are a few examples of general categories of exposure sources. These include household products, pesticides, lead products, lead-containing waste, recreational hazards, contaminated soil, and drinking water. And next slide, please. There are many chemicals that are used in the household. These can include cleaning products and disinfectants, home improvement products, hobby supplies, fuels, and personal care products. Some examples include aerosol sprays, air fresheners, automotive products, cleansers, disinfectants, moth repellents, paints and solvents, and wood preservatives. Sometimes dry clean clothing can contain solvents such as tetrachloroethylene that can off-gas after the clothing is brought back into the house. There are certain hobbies people enjoy that might be associated with use of specific products that might be toxic. Fuels like gasoline can not only be toxic on their own, but sometimes combustion in poorly ventilated areas can also lead to carbon monoxide exposure. Next slide, please. Pesticides are also widely used across the United States. These can include insecticides, herbicides, fungicides, and other products. And it's estimated that 3/4 of US households used at least one pesticide product indoors in the last year. In fact, 80% of most people's exposure to pesticides actually occurs indoors in the household. There are many pesticides that can be especially dangerous to children. So children are not only more vulnerable in general, but they often explore their environment by touching things and putting their hands inside their mouths. Pesticide exposures can occur via skin contact, as well as inhalation or ingestion. Exposure can occur through improper use of pesticides, improper storage, and disposal. Even despite the ban on certain pesticides, sometimes people have old pesticides stored in containers in their garages and sheds. So it is very important to counsel patients to never store pesticides in a container besides its original packaging. There are many different types of pesticides with different harmful effects. One example provided here is cyclodienes. So acute symptoms of exposure can be very nonspecific, such as dizziness, headaches, and nausea. However, long-term exposures to cyclodienes might be associated with liver damage, central nervous system damage, as well as an increased risk of certain types of cancer. Next slide. Lead is an exposure of public health significance. We will have a separate presentation dedicated to lead today, so I won't go into too much detail, but lead is a metal that can affect all body systems. Low levels of exposure can affect the brain, the central nervous system, blood cells, and kidneys, whereas higher levels of exposure can cause convulsions, coma, and death. Children are more vulnerable to the effects of lead due to higher absorption as well as greater sensitivity to lead. Pica is a behavior of eating non-food items, so this might include substances containing lead such as paint chips. This behavior can be associated with other medical conditions such as iron deficiency. During well child visits, it is important for clinicians to discuss diet and nutrition with a particular focus on adequate iron and calcium intake. The effects on fetuses and young children caused by lead can be very severe. Lead is associated with delayed physical and mental development, increased risk of behavioral problems, lower IQ, and shortened attention spans. Next slide. You can see here there are many sources of lead exposure, which again will be discussed in more detail in a separate presentation. Examples include lead paint and dust in homes built before 1978. So lead paint was banned for residential use in that year. Soil can be contaminated with lead from historical use of leaded gasoline or the old paint dispersed from homes during home renovations. Sometimes nearby industries such as metal smelting facilities or battery recycling plants can disperse lead into the surrounding environment. Individuals can also be exposed to lead through food, especially with items such as imported powdered spices like turmeric, chili, and curry powders. Lead chromate, in particular, has been used as an additive in turmeric, cinnamon, and other spices. There are certain cultural products, such as folk remedies, used in Ayurvedic or Chinese herbal medicine, remedies like azarkon, greta, calabash clay, and others that have been found to high levels of lead as well. There are certain cosmetics used in South Asia, in the Middle East, such as kohl, sometimes called kajal or surma, as well as religious powders, such as sindoor, that might contain lead as well. There are certain kinds of jewelry, ceramics, antiques, and toys, particularly those that are imported that can still contain lead-based paint, lead-containing metal alloys, or certain types of plastic that can have lead in them. In the past, there were some candles that were made with wicks that contained lead, although those were voluntarily phased out in the 1970s. And in 2003, the US Consumer Product Safety Commission finally banned the manufacture and sale of lead-cord wicks and the candles that contained them. Next slide. Certain recreational activities can potentially increase the risk of chemical exposures as well. So it is often helpful in the clinic to ask patients about their hobbies and what they do for fun to explore possible environmental exposures. For example, exposure to contaminated water can be due to point or non-point sources during recreational activities. Point source pollution comes from a single place, whereas non-point source pollution is pollution that can come from many different sources, which can make it harder to identify the source of exposure and to address that. There are certain wooden playground structures that may contain pressure-treated lumber, treated with chromated copper arsenate or other hazardous preservatives. Lead and other contaminants can also be found in tire chrome rubber and synthetic turf that is often found in playgrounds. Play sands found in sandboxes, clays, and certain art materials may also contain toxic substances like lead, cadmium, silica, organic solvents, and talc. Children might touch these substances while they're playing and come in contact with the dust or residue that can then be inhaled, absorbed through the skin, or ingested. And young children are often more likely to put their hands inside their mouths, leading to ingestion of these substances. As I mentioned before, sometimes hobbies involve the use of potentially toxic materials. So certain activities to consider paying more attention to include things like stained glass making, where you're soldering the glass, sometimes with lead solder, jewelry making, again, working with metal, model building, sometimes including exposure to organic solvents from the glues, oil painting, airbrush painting, woodworking, etc. Next slide. Drinking water is another potential source of exposure to chemicals. Drinking water can be contaminated from many different sources, such as industrial and agricultural waste, although some contaminants occur naturally in the environment. Examples of potential contaminants include industrial solvents, heavy metals, pesticides, and fertilizers. Lead, for example, can contaminate drinking water via lead-containing plumbing materials. Contaminants in drinking water may cause gastrointestinal illness, neurologic disorders, and reproductive problems. Infants, young children, pregnant women, elderly individuals, and immunocompromised people are particularly vulnerable. In rural areas, sometimes people have private wells, and these wells might contain nitrates. Nitrates can occur naturally in the environment or come from human-made sources, such as the use of certain fertilizers or manure in agriculture. And these substances can seep into groundwater and cause methemoglobinemia when ingested. Infants who consume infant formula prepared with water containing high levels of nitrates may be at particularly greater risk as well. Boiling the water will not reduce nitrate levels. And in fact, boiling water might lead to evaporation of water and increase the concentration of nitrates in that water. Methemoglobinemia is a potentially life-threatening condition that occurs when the oxygen carrying capacity of hemoglobin is decreased due to conversion of the iron in hemoglobin from the Fe2+ state to the Fe3+ state. Organic solvents and other hydrocarbons, such as trichloroethylene, also known as TCE, can make their way into the drinking water supply too. In 1985, the U.S. Environmental Protection Agency, EPA, estimated that TCE was present in approximately 34% of the nation's drinking water. And more recently, between 4.5% and 18% of the drinking water supply sources tested annually by EPA have some degree of TCE contamination. TCE exposure is linked to certain types of cancer, and other adverse effects include liver injury, renal tubule damage in the kidneys, autoimmune disease such as scleroderma, and nervous system effects, including trigeminal neuralgia and impaired vestibular function. TCE can also affect the male reproductive system as well as fetal development. And there are some studies that also showed associations between TCE exposure and fetal cardiac malformations. And in addition to these, there are also emerging contaminants of concern. One example is a broad group of per- and polyfluoroalkyl substances, or PFAS, and we will talk more in depth about PFAS later today in a subsequent presentation. Next slide, please.